Pediatric congenital abnormalities. In this module, we will describe the presentation and treatment of necrotizing enterocolitis and explain the pathology, clinical presentation, and medical management of selected congenital anomalies. Many times the children you work with as a WOC nurse will present as this little girl with multiple issues that may be life-threatening. Understanding some of the congenital anomalies these children have, etiology, presentation, and medical management will help you provide excellent care to these little ones. The GI anomalies listed on this slide will be talked about in this presentation. Some of these, as you will learn, may not be definitively diagnosed until the individual becomes an adult. Let's start with a review of embryologic formation of the gastrointestinal system. During normal development, the alimentary canal starts as a rudimentary tube, closed at both ends and connected to the yolk sac in the area of the midgut. Key developments occur between the 4th and 8th developmental weeks, with the proximal to distal pattern of differentiation, that is, starting at the top and working its way down. At the end of the 4th week, the proximal end opens and starts to communicate with the amniotic fluid. The mouth, pharynx, and respiratory tract begin to open up. At the 6th to 8th weeks, separation of the intestinal and genitourinary systems and formation of the anal canal begin. Cloaca, or the cavity into which the fetal, gastrointestinal, and genitourinary systems empty, and during this week 7, the urorectal septum forms and separates the two systems. The fetus takes in amniotic fluid and excretes it through the kidneys as urine. In the 8th week, the membrane covering the anal opening ruptures. Total tube from mouth to anus is now formed. From week 7 to 12, the midgut or small intestine undergoes tremendous growth and is too big for the fetus abdominal cavity. Therefore, the midgut will herniate out into the umbilical stalk and continue to grow and develop. Once the abdominal cavity is large enough, this segment returns to the abdominal cavity. As this occurs, the midgut will rotate in a counterclockwise position, which provides the anatomically correct positioning for bowel segments and mesenteric attachments. Atresia comes from the Greek words a, meaning without, and tresis, meaning hole or opening. So atresia would mean without an opening. Intestinal atresias mean that the intestine is not complete or open and ends in a blind spot. The areas can vary from the duodenum, which is the rarest, to jejunal or ileal. Symptoms include bilious vomiting and abdominal distension. In other words, the signs of intestinal obstruction. Atresias are usually diagnosed prenatally during the 3rd trimester with an ultrasound. A fetal MRI can also be done, as those born with intestinal atresias can have other congenital anomalies as well, which include heart conditions, cystic fibrosis, and trisomy 21, for example. Moms may be diagnosed with polyhydramnios, that is too much amniotic fluid. This occurs as the fetus swallows but is unable to excrete the amniotic fluid. Atresias are a result of failure of the gut to canal, or develop a canal or tube, or some type of vascular accident in utero, such as something happening during the normal rotation of the bowel. Surgery is done as soon as possible after the delivery, and it's preferable if the baby can be born in a tertiary care center so that all the needed specialists are readily available. Initial treatment includes a nasogastric tube for decompression of the gut, IV fluids, and additional tests such as contrast X-rays in order to better define the problem. Surgical intervention is a must, with one-stage restoration of the intestinal continuity usually performed. Goals for surgery include restoring intestinal continuity and maintaining maximal intestinal length so the individual does not suffer from short gut syndrome in the future. On occasion, an ostomy is required. Long-term prognosis is very good, with a 90% survival rate. Children who die usually succumb to other congenital anomalies that are coexisting with the intestinal atresia. Potential long-term complications include mechanical bowel obstruction, difficulty with feeding, and absorption difficulties. Enteral feedings are the preferred route for nutrition in this case, such as the use of a gastrostomy tube. Biliary atresias are blind pockets within the biliary tree and require surgical intervention, most commonly done using the Kasai procedure. Imperforate anus is also called or classified as anorectal malformation. In this situation, the anus is absent. In the photograph you see on the slide, you can see an anal dimple, but the opening is actually closed. The condition is also associated with other anomalies, such as vertebral anomalies, cardiac malformations, tracheoesophageal fistula, and sometimes esophageal atresias, renal problems, and sometimes limb deformities. Now, the imperforate anus can be classified as high or low. A low classification means that the malformation is located below the levator ani complex, so the correction is less involved. If the classification is high, or high imperforate anus conditions, the anal opening is actually located above the levator ani complex and will require complex surgical reconstruction, requiring a diverting ostomy. An excellent physical exam, noting the absence of anal opening along with a lack of bowel movement, provides a high degree of suspicion that imperforate anus is present. This is followed by a radiographic contrast study that will delineate the problem. Surgical correction includes an immediate ostomy and attention to any and all life-threatening anomalies such as previously noted. Anoplasty or reconstruction of the anus with a pull-through procedure are the surgical treatments of choice. This can be done laparoscopically. If a one-stage procedure is done in this fashion, no ostomy is created. Complications include the usual postoperative problems. Specifically, they may have anal stricturing, in which case anal dilatation can help, or fecal incontinence can be a problem. If incontinence remains a problem after maximum efforts with bowel training programs, a Malone antegrade colonic enema or MACE procedure can be helpful. In this procedure, the appendix is used as a channel between the skin and the large intestine. A small stoma is created from the appendix and is usually located at the right lower quadrant. An enema is given through the stoma to flush out the large intestine on a daily basis or every other day. Since this is not a diversionary stoma, no pouch is needed. A large Band-Aid or small dressing is applied to cover and absorb mucus drainage. Postoperatively, ostomy care is the same as for any other pediatric patient with a stoma. Perianal skin care is crucial after ostomy closure, or in the case of a one-stage reconstruction, perianal skin care should be done immediate postoperatively. This includes perianal skin care, anal dilatation, and bowel management. Continence issues may be present throughout the person's life. Perianal skin care includes cleansing with warm water and, if necessary, a pH-balanced soap or perineal cleanser. The skin should be patted dry, not rubbed, and use of a petrolatum-based or zinc oxide ointment can be very beneficial. Change the baby's diaper as soon as soilage occurs to help in maintaining good perianal skin continuity. Stool should be wiped off until it can no longer be seen and fresh protectant products applied. If the skin is denuded, a light application of skin barrier powder prior to application of the skin cream can be very useful. Care should be taken to keep this powder away from the baby's face so it's not inhaled into the lungs. If stricturing of the anastomosis occurs, the licensed independent practitioner will make a determination about the use of anal dilators as seen in the photo on this slide. Individual instruction to the parents or guardians in the use of these dilators is important, and a teach-back method is used to ensure understanding of the procedure. Imperforate anus can result in a chronic condition affecting parts of the body viewed as private, and the physical consequences such as constipation and fecal soiling may be seen as shameful by some. However, the physical problems associated with imperforate anus can also be considered rather consistent and controllable, such as with the help of an enema during the child's growth. If the person has greater control of bowel activity, there is an association with higher levels of problem-focused coping. However, if one has less control of bowel activity, there's a greater chance of emotion-focused coping as seen through escape and avoidance. It's important to be aware of this so appropriate assistance can be given to both the child and the parent. Social support can also be beneficial for parents of children with imperforate anus, and many times friends can offer help. The child's congenital anomalies can be difficult to explain and understood by outsiders, while families in a similar situation may understand better. Parents of children with special needs are exceptionally competent at helping each other, and parent-to-parent support can be particularly helpful. Meconium is the sticky, putty-like material found in a newborn's intestinal tract that is composed of bile salts, bile acids, and cellular debris. It's normally evacuated within about 6 hours of birth. However, in the case of perinatal stress, this evacuation of meconium can happen in utero as the result of a vagal response to that stress. Impaction of meconium in the intestine, usually occurring in the ileum, results in the case of bowel obstruction. Therefore, the baby has symptoms of a bowel obstruction, including vomiting, failure to pass meconium, and abdominal distension. Plain abdominal radiographs frequently demonstrate low small bowel obstruction, with contrast enema examination of the colon is required to establish a diagnosis of meconium ileus. Water-soluble contrast is typically used. Use of solutions to liquefy the meconium is the first-line treatment for uncomplicated meconium ileus. If mucomist fails to clear the meconium, other complications exist, making it a complicated meconium ileus, and surgery is indicated, with the potential for a stoma formation, plus or minus a resection of parts of the intestine. During normal abdominal development, there are 3 divisions of the gastrointestinal tract. This includes the foregut, the midgut, and the hindgut. This will herniate out from the abdominal cavity, where the intestine then undergoes a 270-degree counterclockwise rotation around the superior mesenteric vessels. Following this rotation, the intestine returns to the abdominal cavity with fixation of the duodenal jejunal loop to the left of the midline and the cecum in the right lower quadrant. There are 3 time frames for rotation, starting with stage 1, which occurs at 5 to 10 weeks gestation. This is when the fetus's abdominal contents rotate out through the umbilical stalk. The potential problem here would result in a non-rotation of the intestine. Stage 2 occurs during the gestational week 10, when the intestine rotates back into the fetus's abdominal cavity. The problem or potential problem here would be malrotation. Stage 3 is from week 11 through birth, and the descent of the rectum and fixation of the mesentery occurs. All children with diaphragmatic hernia GASTROSCHISIS and OMPHALOCELE have intestinal malrotation then by definition. Diagnosis is made through the upper or lower GI X-rays with contrast or ultrasonography. As you can see in this X-ray, the duodenum has not rotated to its usual position on the right side of the stomach, and the intestine has not distributed itself in the normal manner, staying on the right side of the abdomen. In the diagram to the right, you can see how the small bowel has become trapped and twisted in the mesentery of the large bowel. You can easily understand then from this diagram how blood supply can be cut off, leading to bowel ischemia. As can be seen in this slide, vascular insufficiency from the twisting of the gut leads to ischemia, infarction, and tissue death. Treatment is surgical and involves reducing the volvulus in a counterclockwise fashion known as a Ladd's procedure. Resection of any dead bowel with anastomosis occurs, and a bowel diversion may be necessary depending on what is found at the time of surgery. If there is doubt as to tissue viability, a so-called second look surgical procedure is done about 12 to 24 hours later after the initial surgery to determine if the bowel is alive or dead. Further resection plus or minus a stoma may be needed. The appendix is always removed as its blood supply may be compromised during the reduction of the volvulus. Additionally, if appendicitis were to occur, it would be very difficult to locate that appendix. It is critical for the surgeon to save as much viable bowel as possible, as well as perform no anastomosis when there is questionable health to the bowel. A diverting ostomy is likely to be needed. Normal weight for a newborn is about 3,400 grams, or 3/4 of a kilogram. Necrotizing enterocolitis, or NEC, affects premature babies. Symptoms suggestive of NEC are seen on this slide and become evident between day 3 to 10 of life. These babies may vomit, have temperature instability, increased gastric residuals with mild abdominal distension, blood in the stool, and irritability and lethargy. When NEC is suspected, the physical exam, lab work, and serial abdominal X-rays provide support for this diagnosis. An ischemic event affects the epithelial cells of the intestinal mucosa, causing it to be prone to insult by the gastrointestinal enzymes, causing autolytic ingestion and damage. This mucosa is susceptible then to bacterial invasion, prone to sepsis as the bacteria invade into the bloodstream. Breastfed babies have a lower incidence of NEC. It is thought breast milk contains immunoprotective factors. Additionally, the carbohydrates in commercial formulas have found to promote gas bubbles in the intestine, or pneumatosis intestinalis, that cause the abdominal distension seen in NEC. Use of antibiotics and nosocomial infection interfere with normal bacterial flora, which compromises the baby's immune response. Treatment for NEC includes early recognition of the problem with bowel rest, nasogastric tube decompression, intravenous nutrition, antibiotics as appropriate, and sometimes surgery. The type of surgery done is dependent upon the areas of the intestine affected, and it is common to have areas of resection with multiple stomas in an attempt to preserve as much of the intestine as possible, that is, to prevent short bowel syndrome. The exteriorization of bowel as stomas also helps to see if further disease remain. In this photograph, you can see two stomas, both of which seem rather edematous. It is not unusual to see multiple stomas following surgery for NEC. Prevention of NEC includes breastfeeding, meticulous hand washing, and gowning as appropriate. In HIRSCHSPRUNG'S disease, there is a congenital absence of ganglion cells in the bowel wall. This extends from the anus upward and is most commonly seen in the rectosigmoid area, although it can affect the entire large bowel. There is a hereditary component to the development of Hirschsprung's disease. The lack of ganglion cells results in a functional obstruction as the intestine is not capable of moving stool through. Signs that indicate the possibility of Hirschsprung's disease include delay in passing of meconium and other symptoms consistent with a bowel obstruction. The diagnostic gold standard is a rectal biopsy done at about 1 to 1.5 centimeters above the dentate line. Tissue is obtained either by suction rectal biopsy or transanal wedge resection. If the cells do indeed come back as aganglionic, operative intervention is done with timing based on the baby's symptoms. If there is a short segment of aganglionic cells, the individual may have a presentation of diarrhea or constipation, and Hirschsprung's disease is diagnosed later in life when the person is worked up for constipation. If the biopsy comes back normal, Hirschsprung's disease is then ruled out. In this contrast X-ray, you can see the abrupt line of demarcation, note the arrow in film A, that indicates the problem area. The segment in white above the arrow indicates contrast material of the ganglionic portion of the bowel, and the aganglionic segment is very narrow. Surgical procedures remove the aganglionic segment of the bowel and rectum with an endorectal pull-through, also known as the Swenson procedure, being the most common. The rectum and sigmoid colon are removed, and an anastomosis to the anal canal is performed. A temporary stoma may be done before definitive surgery is done to serve as protection while the pull-through area heals. Sometimes fecal incontinence can be a problem, so appropriate perianal skin care is a must. With gastroschisis, loops of bowel herniate through a defect into the abdominal wall. The exteriorized loops of bowel are exposed to amniotic fluid, which can irritate the surface of the intestine. Structures affected include those to the right of the umbilicus. One of the major concerns is the potential for ischemic injury to the intestine. OMPHALOCELE, on the other hand, results from the abdominal contents not returning to the abdominal cavity during fetal development. Loops of bowel are exteriorized and covered with amniotic membrane, and other congenital anomalies can be associated with this problem. Both conditions can be diagnosed pre-birth with ultrasound, and once the condition is identified, other anomalies are also looked for. This is helpful as it not only allows the medical team to anticipate what is needed to provide quality care, but also allows the family time to prepare mentally, emotionally, and physically for the birth of their child. The treatment of gastroschisis includes a staged approach. The SSP silicone or silo bag is a cylindrical-shaped dome designed to contain the extra abdominal viscera during reduction of the gastroschisis or OMPHALOCELE. The silo bag is constructed from an implantable-grade silicone elastomer. The clear cast shell allows for visualization of the viscera during reduction with no seam to obscure the contents. The open end of the silo bag has a resilient, non-metallic reinforced silicone ring that is put inside the abdomen and may be sutured into place, providing a closed environment and minimizing peritoneal fluid loss and bacterial contamination while reduction takes place. The distal end of the silo bag has a reinforced silicone loop that may be attached to an overhead support for continuous postoperative traction on the silo bag. The bag is made smaller little by the surgeon, which causes the intestine to gradually go back into the abdomen. Once the intestines are back in the abdomen, the silo is removed and the muscle and skin are closed over the hole in the abdomen. Sometimes the use of negative pressure wound therapy is used for wound closure. Treatment of an OMPHALOCELE includes surgical reduction of the herniated viscera with closure of the fascia and skin. Alternatively, the paint and weight method may be used if the liver is in the sac. In this method, the sac is painted with silver sulfadiazine or other material as designated by the surgeon. A compression device, think of something similar to a corset or silo bag, is then applied, and pressure from the device gradually causes the herniated viscera to return to the abdominal cavity, at which time the fascia and skin can be closed. Congenital urinary tract anomalies include posterior urethral valves, PRUNE belly syndrome, bladder exstrophy, and myelomeningocele. PRUNE belly syndrome is a very rare congenital anomaly in which there is an absence of abdominal wall musculature. These boys have urinary tract anomalies which include large bladders, dilated ureters and prosthetic urethra, and bilateral undescended testicles. Other abnormalities can also be present. Treatment is dependent on the exact nature of the individual's problems. If a urinary stoma is required, pouching will be extremely difficult because there's no abdominal musculature to provide support for the pouching system. In the photograph in this slide, you can see the deeply wrinkled abdominal contour. This individual is at risk for abdominal injury. Lifelong medical follow-up will be required. For the child with bladder exstrophy, the bladder and urethra are open and exposed on the lower abdomen, as you can see in the upper photograph on this slide. Closure of the bladder usually occurs soon after birth, with the bladder neck reconstruction after 1 year. Continence issues are common. With cloacal exstrophy, the person has exposed bowel and bladder with imperforate anus, spinal abnormalities, and hip problems being common. Cloacal exstrophy is seen in the lower photograph on this slide. Surgical correction of the anomalies is needed and based on the child's specific problems. Urinary or fecal stomas may be required depending on the extent of the problem. Myelomeningocele, or neural tube defect, is thought to be caused by genetic factors and folic acid deficiency, but the exact etiology remains unclear. Neural tube defects involve the lamina and pedicles of the vertebral column. This defect occurs when the neural tube does not close properly on either end of or becomes overdistended and ruptures after closure. There has been a decrease in this malformation in recent years as folic acid is being provided prenatally. In some cases, when this is detected with prenatal diagnostic tests, the pregnancy could be terminated. Many of these children have bladder problems, including bladder sphincter dysynergia, which is a condition where the bladder and sphincters do not work in concert with each other. When the bladder is constricting, the sphincter is also constricting, which results in high bladder pressures and reflux up the ureters back to the kidney. This can cause damage to the kidney. Bowel management can also be problematic. However, rarely do these conditions result in a stoma. The Pediatric Best Practice document is an excellent resource for you, and it's full of all types of information to support you in your practice. When you have an opportunity, it could be very helpful to get a copy, particularly if you are caring for a child with one of these anomalies. This ends the lesson on pediatric congenital anomalies. Thank you for your attention.